This last video will cover the Class 2 and Class 3 agents. First, we'll start with Class 2, which are agents that stimulate ion channels in the ventral tegmental area. These drugs directly stimulate ion channels to increase the activity of dopamine projection neurons, which results in increased dopamine release in the nucleus accumbens. Benzodiazepines will only briefly be considered in this video and will be covered in much greater detail as part of the anxiolytic drug action video in IP8. The ethanol and benzodiazepines are considered CNS depressants. In contrast, nicotine is a CNS stimulant. This is in contrast to the opioids and THC that we discussed previously, which are also CNS depressants. The Class 3 agents are also considered CNS stimulants. The first Class 2 agent I will discuss is nicotine. Again, nicotine is a CNS stimulant whose short-term effects include increased alertness, mild euphoria, muscle relaxation, nausea, and increased psychomotor activity. Nicotine addiction exceeds all other forms of addiction in terms of numbers, and that is because so many individuals around the planet use nicotine-containing products. The rewarding effects of nicotine are due to the activation of the nicotinic acetylcholine receptor, which is an ion channel, in the VTA. Chronic nicotine use is associated with dependence, and there is a mild withdrawal syndrome upon abrupt discontinuation that includes irritability, difficulty concentrating, sleep disturbances, and increased appetite. Relapse is extremely common with the use of nicotine-containing products, and smoking cessation is one of the most difficult therapeutic areas. Smoking cessation has been covered previously, but I will briefly review its utility here. The primary therapy for smoking cessation is nicotine replacement therapy, or NRT. And again, this follows the same pattern with the previous substitution therapeutics we viewed, which is that they have improved kinetics and less harmful routes of administration. Specifically, the advantage of nicotine replacement therapy, such as a nicotine patch or a nicotine gum, is slower kinetics, slower onset and offset compared to cigarettes or other chewed tobacco products. They are also less toxic in terms of their additives, and they are less damaging to the lungs because they are not smoked. Even though nicotine is still being delivered to the body, nicotine replacement products are still preferred to cigarettes or chewed tobacco products because of their reduction in adverse effects and long-term effects. Another agent available as a substitution therapeutic for smoking cessation is varenicline. Varenicline is a nicotinic acetylcholine receptor agonist that stimulates nicotinic acetylcholine receptors specifically in the central nervous system. This provides a mild level of substitution for the acute effects of nicotine, but again, with less harmful and less problematic adverse effects. The last agent approved for smoking cessation is bupropion, which is an antidepressant. It is commonly combined with cognitive behavioral therapy to produce smoking cessation. Bupropion will be discussed in much greater detail in IP8 with the other antidepressants. Next is alcohol, the active component of which is ethanol. Ethanol has a very complex pharmacology that includes activation of many different receptors and ion channels, but it fits most commonly into the Class 2 agents because its primary effects to cause dopamine release in the nucleus accumbens are via ion channel activation in the VTA. Ethanol is known to stimulate GABA receptors, potassium channels, NMDA receptors, glycine receptors, and the serotonin ion channel 5-HT3. However, it is unclear which ion channel is most important for dopamine release, and it is likely a combination of all of its effects. The short-term effects of ethanol include loss of inhibition, an anxiolytic effect, sedation, and loss of motor coordination. One of the main problems with using alcohol or ethanol as a substance of abuse is that very large quantities or concentrations are required to produce its psychoactive effects. And this means that there are significant health risks or toxicity associated with its use. These are primarily risks with liver function, but there are other long term effects as well. Chronic ethanol use produces dependence, and there is a very severe withdrawal syndrome that includes a variety of signs and symptoms. Within 6 to 12 hours after stopping alcohol consumption, you will see tremor, nausea and vomiting, sweating, agitation, and anxiety. Within 1 to 2 days after stopping ethanol ingestion, seizures may develop, and within 2 to 3 days, you may observe the presence of delirium tremens. Delirium tremens, or DTs, is a severe form of alcohol withdrawal that usually appears after 2 or 3 days of stopping heavy drinking. It is characterized by the rapid onset of severe confusion and changes in blood circulation in the brain and breathing. Delirium tremens is life-threatening and is associated with coma and possibly even death if untreated. The DSM-5 criteria for alcohol use disorder are similar to those for opioid use disorder, but simply replace the word opioid with alcohol. Again, for instance, this includes alcohol being taken in larger amounts over a longer period of time than intended, a persistent desire to cut down that is unsuccessful, a great deal of time being spent obtaining and using alcohol, craving for alcohol, etc. Again, similarly to opioid use disorder, mild disease is considered 2 to 3 symptoms, moderate disease is 4 to 5, and severe is 6 or more. The treatment approach for alcohol use disorder depends on what phase of the disorder is being treated. In the case of alcohol overdose or intoxication, the primary treatment is simply IV fluids to dilute the concentration of alcohol in the bloodstream. For withdrawal, as I mentioned, this is a life-threatening condition that does require immediate treatment. One of the ways that withdrawal can be diminished is actually through the administration of more alcohol or ethanol. So during withdrawal, either oral or IV ethanol can be used to reduce the appearance of a withdrawal syndrome. Another pharmacologic agent that can be used for withdrawal are benzodiazepines. Benzodiazepines are also CNS depressant drugs that have a very similar pattern of activity to alcohol or ethanol. However, their pharmacokinetics are a bit elongated and they have longer durations of action with lower hepatic metabolism and therefore allow a patient to get through the withdrawal period more safely. For alcohol use disorder itself, there are 3 therapeutics that can be used to prevent relapse. And in this particular case, none of these are substitution therapeutics. Rather, these are all agents that are used to prevent relapse or craving for alcohol. The first is acamprosate, which is an NMDA antagonist that restores a neurotransmitter balance in the brain thought to predispose to relapse and craving. Naltrexone is an opioid antagonist that can be administered orally and is also thought to reduce relapse and craving in alcohol use disorder. Disulfiram or antabuse is not as commonly used anymore, but this is a therapeutic that decreases the metabolism of alcohol such that if someone drinks heavily or binge drinks, they will feel extremely sick and experience significant nausea and vomiting when disulfiram is being taken at the same time. Other drugs that fit into class 2 include the benzodiazepines, ketamine, and PCP. The benzodiazepines are drugs commonly prescribed as anxiolytics and sedatives or sleep medications. As I mentioned, these will be discussed in greater detail in IP8. Their rewarding effects are due to activation of GABA A receptors in the VTA, and this is an ion channel, which makes them class 2 agents. Benzodiazepines are sedative and anxiolytic, and dependence is common, which leads to a withdrawal syndrome that can include irritability, insomnia, depression, and possibly even seizures. Ketamine and PCP are known as the dissociative anesthetics. They were originally developed as general anesthetics, although only ketamine is still used as such. Their effects are primarily due to NMDA inhibition or antagonist activity in the VTA. They are typically thought to be non-addictive drugs of abuse. Their acute effects include vivid dreams, which can oftentimes be very unpleasant, as well as hallucinations. Chronic exposure to ketamine or PCP can cause a long-lasting schizophrenia-like psychosis. Last, we will discuss the class 3 drugs, which include the stimulants and MDMA or ecstasy. Again, these are drugs that directly act in the nucleus accumbens to inhibit the reuptake of dopamine, thereby greatly increasing concentrations of dopamine in the synapse in that brain area. The two primary stimulants include cocaine and amphetamine. Cocaine is a dopamine transporter or DAT inhibitor, which prevents the reuptake of dopamine once released in the nucleus accumbens. This leads to a large increase in dopamine concentrations in the synapse. Amphetamine is also a dopamine transporter active drug, but instead of simply blocking DAT, it is actually reverse transported into the synapse where it displaces dopamine from the nerve terminal and causes massive release of dopamine in the synaptic space. The stimulant cocaine is a naturally occurring plant alkaloid found in the coca plant native to the Andes Mountains in South America. It has sodium channel blocking activity and was originally developed as a local anesthetic. And as you can see in this image on the left side of the screen, was previously marketed for preparations such as toothache drops, which makes sense given its local anesthetic sodium channel blocking activity. However, it also blocks dopamine reuptake, in addition to at higher concentrations also blocking norepinephrine and serotonin reuptake. This leads to significant activation of the sympathetic nervous system and short-term effects of euphoria, increased arousal, suppression of fatigue, hypertension, tachycardia, as well as the possibility of arrhythmias. The amphetamines include amphetamine and methamphetamine, both of which inhibit the reuptake and also stimulate the release of dopamine and norepinephrine. And this is called reverse transport. Their short-term effects are similar to those of cocaine and include hyperactivity, insomnia, hallucinations, and loss of appetite. One important thing to note about methamphetamine is that it is a known neurotoxin specifically to dopamine and serotonin neurons and actually can cause their damage and potentially death. Consistent or chronic stimulant use is associated with a withdrawal syndrome that includes dysphoria, fatigue or exhaustion, anxiety, and depression. The last drug of abuse I will talk about is MDMA or ecstasy. Ecstasy is an interesting drug because in the 1950s and 60s, it was originally used in psychotherapy to foster feelings of empathy and intimacy without impairing intellectual capacity. Its mechanism is that it inhibits the serotonin transporter, SERT, and actually can cause reverse transport of the serotonin transporter, leading to large increases in serotonin concentrations in the brain. However, it does also do this for dopamine to a certain extent at higher concentrations, and therefore can produce feelings of euphoria as well as other side effects. It is associated with a possible long-term cognitive impairment due to neurotoxicity. Its other acute or short-term effects include increased body temperature or hyperthermia, dehydration, serotonin syndrome, and possibly even seizure or death. MDMA has recently been reinvestigated as a psychotherapeutic, and it will be interesting to determine whether or not MDMA will have any therapeutic benefit going forward in conditions such as PTSD, depression, and autism. Even though we know a lot about substance use disorder, we still have a long way to go in terms of treating this debilitating disease state. This graphic, which is from the same survey displayed previously, shows the number of people who needed specialty substance use treatment but did not receive it. So out of the 19 million people who needed but did not receive substance use treatment, the vast majority, almost 18 million, felt that they did not need treatment, even though clearly this was not the case because they met the criterion for substance use disorder. So we really have a long way to go in terms of destigmatizing substance use disorder and leading to better treatment options and outcomes for individuals who suffer from this disease. Take a moment to review some of the pharmacologic options that are available to treat either opioid use disorder or alcohol use disorder. What therapeutics are out there and what stages of the disease do they treat? Snap a pic of the QR code for help answering this question.